And yes, so great to see so many familiar faces. Just a few quick things to mention. We are indeed recording, and this will be posted on the MFSN website later, and so will the slides. So fear not if you didn't catch every single word or have a colleague you want to share this to. Please use the chat feature. We'll be monitoring it throughout. And please make sure you're muted so we don't have any embarrassing boo-boos. Let's go to the next slide. So our objectives today are to increase awareness about some food security and food as medicine topics, and we'll say more about the speakers we have, but we have an action-packed agenda, and there'll be a lot of focus on local food in today's programming, and also on food security screening and FIM sustainability. We can go to the next slide. Just as a refresher about what MFSN is, we are a network that is co-convened by Share a Strength, which is a national child hunger nonprofit, and Health Begins, which is a upstream drivers of health consulting organization. And together we work on influencing the Medicaid system, particularly at the state level, to adopt and implement effective strategies to support the full spectrum of food needs for children and families, including closing the enrollment gaps in the SNAP and WIC federal nutrition benefits, and also increasing access to food as medicine programs. And we do so through creating spaces like these where we all get to come together and say hello to each other and learn from each other in different states. We do it through creating tools for policy and advocacy, such as our policy dashboard and some policy briefs. And we also do it through technical assistance, particularly that which is led by our friend Catherine Jantz from Hearthwise Consulting, where we are trying to work together and learn from all of you great state advocates. Let's go to the next slide. Here's a quick plug for our policy dashboard and our legislation tracker. These are things you can use to track what's going on in different states, and because sometimes the most effective thing you can do is say, they do something in this other state, and here's why we should do it in my state. Let's go to the next slide. We are continuing to gather feedback on MFSN, and so there's a QR code here. And we can also put some of these links in the chat shortly, but there's a survey that we're encouraging folks to take that pertains to the content of our news digest and just some of our general resources. Please feel free to take that so that you all are helping us make the network be what you all need it to be. Let's go to the next slide. So I wanted to mention just at the top of the meeting, and I hate to drop a bit of a life update truth bomb at the beginning of the thing, but just want to let folks know that I will actually be transitioning out of this role at Share a Strength due to the fact that my wife was made an offer she couldn't refuse involving moving to London. So unfortunately, I won't be able to stay in this position past June 8th. But just wanted to take like 30 seconds to say thank you to all of you for all the amazing work you do and for being part of this network. And to also just reassure that thanks to the strong backing of Share a Strength and Health Begins and the great team that I work with, there will be continuity in this work, and it will not feel terribly different for most of you, more so than it might feel different for me. And to that end, we will still be naming 4 organizations soon to join our MFSN Partners Program to be grantees of our network, and they will get to do some amazing things together. So we can chat more in the later time. So I will keep us moving, but just wanted to say that up top. All right, next slide. And thank you for all the lovely comments in the chat saying nice things about me. Maybe one day my parents will read some of these. Okay, so the agenda for today. we're first going to hear from some national experts. So Lindsay Johnson from the Rockefeller Foundation to talk about the From Farm to Fin report that was released recently. We're going to hear from Rich Stewart at Children's Health Watch about a fantastic data dashboard on food security screening, and also hear about the MTM sustainability blueprint from our friends Erica and Alyssa at Chilpy and FIMIC respectively. And then we'll spend some time hearing from our friends in Missouri. So that's Trina Reagan, and West Virginia. That will be, sorry, Reagan, I kind of cocked up your name there, from Trina. And West Virginia, we'll hear from Gina and Marinda about West Virginia's food as medicine legislation. So very interesting state stories that we'll get to hear. And then in the final bit of the time we have together, we'll have breakout rooms where things will function as a Q&A space, and you'll get to hear from each other and the speakers a bit more. So feel free to ask questions in the chat as the speakers speak, but also just know that there is a space in which you can also ask it, and it'll be a little bit more of a small group by then. So for those of you who can stay for the full hour and a half, please do, but we also know some of you do need to drop at the hour mark, and we'll try to get all the talks done by then. All right, let's go to the next slide. As maybe typical for these convenings, I think I'm going to skip reading the biographies of everybody, but just know that everyone you're about to hear from is a very, very smart and powerful person, and you'll learn a lot from them, and we thank them for their time. All right, let's go to the next slide. Next slide. And next slide, we'll hand it over to Lindsay. Thank you so much.
Great. Thanks so much, Julian, and very happy to be here. Thank you all so much, and excited to share this work with you. Next slide, please. So nearly 2 months ago now, we released a report that aims to examine a timely and practical question, which is how can food as medicine programs improve health while also supporting farmers and strengthening state economies? Food as medicine interventions, such as medically tailored meals, medically tailored groceries, and produce prescriptions, are rapidly gaining momentum across the country. Health systems, insurers, and states are increasingly recognizing the opportunity to provide nutrition as a clinical intervention to prevent and manage chronic disease. Next slide. And we know that the need is very significant. Nearly half of American adults live with a diet-related chronic condition, costing the US over $1.1 trillion annually. And at the same time, farmers are under increasing economic pressure, with roughly 20 to 30,000 farms disappearing each year on average. So in our work at the Rockefeller Foundation, we're interested in how we can address these two challenges together. Next slide, please. And so what makes this moment particularly important is that many states are now designing food as medicine programs for the first time, setting coverage pathways, defining procurement approaches, and determining how services are delivered. And so these early design decisions will shape not only how health outcomes are achieved, but also where food is sourced, who participates in the market, and how economic benefits are distributed. So at the Rockefeller Foundation, we've supported food as medicine initiatives for several years, including large investments in the clinical research that's increasingly proving out the efficacy and cost effectiveness of FIM programs, and policy support and technical assistance at the federal and state levels to design and implement effective programs, and in FIM providers themselves as they build the technology and infrastructure to deliver FIM at scale, including the capacity to connect FIM to local food systems. And we've been excited to see that already more than a dozen states have added food as a covered benefit to their Medicaid programs through an 1115 waiver or ILOS. Next slide, please. And so as these programs scale, there's a central question that really emerges. Who delivers these services and where does the food come from? These are program design choices that will determine whether food as medicine functions solely as a healthcare intervention or whether it also becomes an economic driver that supports farms, creates jobs, and strengthens regional food systems. And so this report really focuses on the economic dimension and quantifies those potential impacts at a state level and national level. really to provide a directional estimate of the size of the opportunity when FIM programs prioritize local food and local FIM providers to the best of their abilities. Next slide, please. So we began by estimating the size of the potential market. Approximately 43 million Americans have both a diet-related chronic disease and an economic barrier to accessing healthy food. And so this is who we considered the FIM-eligible population for this analysis. And so if food as medicine programs were scaled to serve this population, they would generate over $50 billion annually in demand for food as medicine services. Next slide, please. So we then conducted a state-by-state analysis to estimate how much of that demand could realistically be met locally within each state based on current agricultural capacity and food systems infrastructure. And so the top line finding, when combining those state-by-state outcomes into a national aggregate, is this. When food as medicine programs prioritize local sourcing and locally based providers, they can contribute over $45 billion in annual economic activity nationwide, support more than 316,000 jobs across the value chain, and deliver at least $5.6 billion in annual revenue to small and mid-sized farms. Next slide, please. So the report highlights three primary pathways through which these impacts can occur. The first is direct revenue to farmers. Local sourcing creates new and more stable markets for small and mid-sized farms, which make up the majority of farms in the United States. But these are also the same farms that are often facing the greatest barriers to accessing institutional buyers. And so importantly, in addition to the scale of revenue, we're seeing this market create opportunities for predictability of demand through forward contracts or forward purchasing commitments, which can really de-risk production decisions and enable longer-term investment for farmers. The second is economic activity across the supply chain. Food as medicine programs rely on a range of services across the value chain beyond food production, including aggregation, storage, processing, meal preparation, in some cases for medically tailored meals, and delivery and last mile logistics. So when these functions are carried out by locally based providers, more of the associated spending remains in state and circulates through local economies. And third, we discuss longer term system benefits of regionalization. And while we don't quantify this in the report, it's also still very important. And these really include kind of stronger and more resilient supply chains, greater capacity to withstand disruptions, and improved conditions for farmland conservation and sustainable production practices. Next slide, please. And so a key conclusion of this report is that these outcomes are not automatic as food as medicine scales. They very much depend on how programs are designed. And that means first and foremost, building FIM programs that explicitly prioritize local FIM providers to carry out the programs and food sourcing from local farmers. And in doing so, there's an opportunity for coordination across agriculture, health, and economic development agencies. There's also a need for greater investment in value chain infrastructure, which can influence how much of this opportunities states can actually realize. And so in the report, we also lay out additional guidance for designing local food as medicine programs from early design to more mature stages. Next slide, please. So I also just want to say a few words about the methodology to help contextualize the findings. And a quick note that we partnered with Dahlberg Advisors to help us develop the methodology and create the model that we used for this analysis. So the findings are based on a national and state level economic model built using available data on population health, food systems, and regional economies. And so there are a few important considerations for interpreting the results. First is that the analysis assumes full participation among the eligible population. In practice, current enrollment is much lower, so these figures represent potential at scale, not near-term projections. Second, the analysis incorporates state-specific assumptions about local sourcing capacity, recognizing that not all states have the same ability to meet demand locally today. Third, the estimates reflect gross economic activity. That is the total economic contribution of food as medicine spending, without subtracting for potential shifts from other markets. And fourth, we use the most recent available data, but we don't make predictions about future macroeconomic trends or policy changes that may affect labor markets or input costs. So for these reasons, the findings are best understood as a directional estimate of the scale of the opportunity rather than precise forecasts. And to support transparency and usability, all of our assumptions, data sources, calculations, limitations of the model are all documented in a technical appendix, and the full analytical model is also available for download on a website, and I'm happy to put the link in the chat after this. Next slide, please. So in addition to the main report, I want to just point out in particular these state fact sheets that we developed for all 50 states. And so what you see here is an excerpt of a more complete two-pager that provides the state-specific top-line findings, as well as a number of other analytical findings and descriptive statistics. Next slide, please. And so you can find these on the report landing page by going to this interactive map, clicking on your state, and then you'll see a link to download the fact sheet. Next slide. So again, in addition to this main report, there are several complementary resources also available on the landing page, and highly encourage you to check that out in conjunction with the report. We have the state level fact sheets for all 50 states, summarizing key findings and context-specific data, the interactive map, and then the technical appendix detailing the full methodology, as well as the analytical model itself in Excel form. So that documents all the inputs and calculations and can also be adapted for further analysis as well. Next slide. And so across the field, we're seeing significant momentum to integrate local food sourcing and community implementation into food as medicine programs. At the Rockefeller Foundation, we're supporting a cohort of grantees who are doing this work on the ground. And I just want to highlight a couple of these, and they're the ones we also featured as case studies in our report as well. So first, Community Servings is in Massachusetts and operates within a Medicaid 1115 demonstration waiver that funds medically tailored meals and groceries for Mass Health members. They deliver medically tailored meals and medically tailored groceries to nearly 8,000 clients, and they achieve over 20% local sourcing through direct farm partnerships, utilizing regional aggregators like the Boston Food Hub, and forward contracting. Next is FreshRx Oklahoma, and they are a produce prescription program in Tulsa that connects patients with diabetes to fresh fruits and vegetables through clinical referrals. And they operate in a bit of a unique policy context in that Oklahoma doesn't currently have an 1115 waiver or ILOS covering food as medicine, but they have recent state level legislation that's begun to formally recognize and support produce prescription and food as medicine approaches outside of Medicaid. And FreshRx actually achieves 100% local and regenerative sourcing by partnering directly with Oklahoma farms and regional food hubs. And lastly, I'll just note Recipe for Health is another fantastic example based in Alameda County, California. And they operate under CalAIM, which is the state's Medicaid waiver that allows managed care plans to offer produce prescriptions as community supports. And they source also 100% of their produce locally within 250 miles and prioritizing BIPOC-owned farms and organic and regenerative practices. And so in addition to these on-the-ground examples, there are also increasing momentum in the policy landscape to increase local sourcing in food as medicine. Last year, our grantee Chilpy, and I see Erica's also on the call, the Center for Health Law and Policy Innovation, came out with a report that laid the foundation in many ways for this Farm to FIM report. And that report is on the screen, titled Maximizing the Impact of Nutrition Interventions with Local Food Procurement. And that does a really excellent job in laying out kind of a very comprehensive framework for how states can align FIM procurement with local food systems values. And there are several examples featured in that report that really do a very technical illustration of how states can embed local sourcing and kind of community-based provider requirements directly into their FIM policies and procurement frameworks. And so taken together, these examples really show that the infrastructure for local FIM is being built from both directions, by providers embedding local sourcing into their operations and by states writing it into their policy. Next slide. And so I'll just close with this, and it's that food as medicine is most often discussed in terms of health outcomes, and that remains absolutely central. But as these programs scale, they also represent a significant and growing flow of resources into the food system. And the choices that we make now will determine how the benefits of those resources are allocated. And if there's one thing we hope you'll take away from this report, it's that there is a window of opportunity right now to shape how FIM programs are designed and ensure that local economic and agricultural impact is also prioritized. So thank you so much. And Julian, I will turn it back to you.
Thanks, Lindsay. Appreciate you sharing about the report. And I also put the link in the chat for everyone. At this time, I'll hand it over to Rich Stewart from Children's Health Watch.
Thanks, Julian. It's great to be here with you all. We can go to the next slide. I'm Rich Stewart, and I'm the Director of System Implementation Strategies with Children's Health Watch, which is a national research and policy network headquartered at Boston Medical Center, focused on early childhood as well as infants and toddlers families. I'm going to walk you through our new data dashboard, and we can do a demo of that later on in the breakout room. So we'll go to the next slide. Just to put this in context, why is Children's Health Watch creating this dashboard now? I unfortunately must tell you that the reason is because the federal data infrastructure that we have all leaned on for years and years is getting smaller. At least in the last year, it's been getting smaller. Notably, the CPS food security supplement was ended last fall. That's what fuels the USDA food insecurity report every year that tells us how many people in the United States are experiencing food insecurity, to what degree, break it down by demographics. We're not getting that in the near future. Survey budgets, so publicly available research studies their funding is being cut, and public dashboards are going offline. And so we built this dashboard to really do the opposite, to take the 28 years of Children's Health Watch data. This is caregiver reported data on the status of infants and toddlers in the United States, and put that into the hands of people who actually use it. Parents, advocates, journalists, researchers, policymakers, and all of you on this call. And when we set out to create this dashboard, we wanted to make sure that we got three principles right. One was that it'd be customizable. Two, that it would be continuous and open. And three, that there would be no login, no paywall, that this would be free to everyone, for everyone to use and access. We'll go to the next slide. So I'll tell you a little bit about what is behind the dashboard. This is all data that was collected over 28 years, since 1998, by researchers at Children's Health Watch. And so we have over 80,000 interviews with families experiencing things like food insecurity, healthcare hardships, housing instability, homelessness, trouble keeping the heater lights on, who come to safety net hospitals in 4 cities in the US. We are in Boston, Philadelphia, Little Rock, and Minneapolis at safety net hospitals, majority Medicaid population. And we're specifically focused on caregivers with infants and toddlers. So all of our interviews are with families that have an infant or a toddler under the age of 4. And again, what's driving the data is that we've built everything on validated instruments. And so we are using the 18-item USDA Household Food Security Survey module in all our interviews. We're using validated housing and energy insecurity measures. And I will also mention that our full survey is publicly available. It's at the link below, so feel free to dig in to understand exactly what we're asking families and what drives the data that we have available. We'll go to the next slide. So I'm going to walk you briefly through this grid. What we've included It's not everything in all of the surveys that we've collected, but the things that we think would be most useful to all of you. So we have 9 domains, all interconnected. So we have the 4 big hardships at the top, as I mentioned. We also include in this dashboard outcomes for both children and caregivers. That's in the middle row. And then critically for this group here, program participation. So looking at participation in SNAP and WIC and Medicaid, as well as housing subsidies. And we're able to look at trends by demographic characteristics as well. Every one of these domains can be sliced and diced multiple ways. Go to the next slide. And so when I say slice and dice, what I mean is that every domain you can filter by site. So you can look at our national data, or you can just look at Boston, or just look at Little Rock. You can filter it by year, individual years, periods of time, like the last 10 years, or all 28 years together. You can look at it by race and ethnicity. You can look at it by nativity, foreign-born mothers versus US-born mothers, employment status. We can even look at it by caregiver health insurance status and separately child health insurance status. And I think the insurance breakdown is where the Medicaid Food Security Network audience might be really interested, because these conversations tend to want to look at populations based on participating in Medicaid versus participating in SNAP, and where are there gaps, so we can see that. Yes, so not to be confused with the Epic Slicer Dicer, which is a very different and also incredibly useful tool. We can go to the next slide. So as I mentioned, when we move to the breakout rooms after presentations, I'll pull up my browser and show you a live demonstration. But you can also go at the bottom of the screen is the link to our dashboard. It is on our website. You can access it anytime. But really the best way to use it is to first look at larger trends and get familiar with it before you then decide to sort of drill down on a specific story or pathway that you're most interested in, whether it's looking at food insecurity by a certain demographic like health insurance status or race or ethnicity. But really what it's going to allow you to do is build a snapshot that you can use for a briefing to a policymaker, an op-ed that you're working on, something that's very time sensitive and salient, or testimony that you're preparing at the local, state, or federal level. So we really want this to be a useful tool for you all. And I just have 2 more slides, so we'll go to the next one. I said a little bit about how you might put this to work. 4 things that I'll flag. You can use this for your conversations with state Medicaid and SNAP administrative agencies. Those conversations are more important now than ever, so bringing data to them is really useful. As I mentioned, you can use this for testimony-ready snapshots. This can be a helpful counter-narrative. As I mentioned, the USDA food security report has gone dark. So now this, and there are other researchers out there who are showing rates of food insecurity among different populations. So this can be a nice dovetail and companion to what others are doing, because this is obviously, as I mentioned, specific to infants and toddlers and those families. And if you're a researcher, you can also use this as a bit of a hypothesis generator. So thinking about your own research or your own policy analysis. We'll go to the last slide. The link is right here. You can, as I said, go to this anytime. There's no login, there's no cost. I urge you to share it with your teams and your organizations. And if you have any feedback, because we just launched this in the last few weeks, please contact me. My contact information is here. We would love to improve this. So as you're testing it out, let us know what you like about it, what you think should be improved. Right now, we're working on the function to export individual charts and snapshots that you create into PDFs so that it's really easy to take that and put it into use. And so that's one function that is right on the horizon, but would love any feedback that you all have. And I'll pass it along now. Thanks, everyone.
Thanks so much, Rich. I was saying to Lindsay the other day that I think I should get a tattoo of $5.6 billion on my arm, but when things are on the internet, maybe you don't need to use tattoos to remember some really great data to support the things that you're working on. All right, going to pass it over to Alyssa and Erica.
Hi, everyone. I'm really thrilled to be here. Thank you, Julian. Thank you, MFSN. We have only 8 minutes to get through the blueprint, so we're going to go ahead and jump right in. For those of you who are unfamiliar with me, my name is Alyssa Wasung. I'm the Executive Director of the Food is Medicine Coalition. And Erica and I are actually going to go through just a little bit of intro to both of our organizations in one moment. So, Erica, welcome into the conversation. What we have done here with the Medically Tailored Meal Sustainability Blueprint, we're really thrilled to present it to you, is really grapple with how we bring food as medicine interventions into the healthcare infrastructure, making them more sustainable and accessible, and eventually leading to covered benefit status in health insurance coverage. To do that, we actually need to articulate how those services fit into the existing legal frameworks that federal agencies must use and states must use for all covered benefits. So that's what the blueprint does. It performs this translation for the medically tailored meal model in the context of Medicaid. Next slide, please. So who are we, FMIC and CHILPI? I think some of you may be familiar with our programs and our mission, but in short, I'll describe FMIC and pass it over to you, Erica, to describe CHILPI. FMIC is the National Convening Coalition for Nonprofit Organizations that provide medically tailored meals and medically tailored groceries alongside medical nutrition therapy and nutrition counseling and education. And we're providing these services free of charge to people in communities across the country who are living with severe, complex, and chronic conditions. Our goal, our mission, is to advance access to these life-saving interventions through service, policy change, research and evaluation, and best practices. And all four of those mission pillars kind of come together in this blueprint, and we'll explain why. Really importantly, FMIC agencies actually created the medically tailored meal intervention over 40 years ago as a response to community need, and we've been maintaining those nutrition standards ever since. We offer a community of learning for existing practitioners. We also equip new organizations to launch medically tailored programs, and we accredit agencies against our field-wide standard for medically tailored meals. Over to you, Erica.
Thank you. The Center for Health Law and Policy Innovation of Harvard Law School, or CHILPI for short, advocates for legal, regulatory, and policy reforms to improve the health of underserved populations with a real focus on the needs of low-income people living with chronic illnesses. At its core, CHILPI works with a wide array of partners, including many of you on this call, to promote more equitable and effective healthcare and food systems. We're a clinical teaching program of Harvard Law School, and we're comprised of both the Harvard Law School Health Law and Policy Clinic and the Harvard Law School Food Law and Policy Clinic. As part of this project, both FMIC and CHILPI want to acknowledge and thank the members of the Food is Medicine Coalition for contributing their time, expertise, and review of the development of the medically tailored meal blueprint. And also this report was made possible through the really generous support of the Doman Company Foundation. Next slide, please. And back to you, Alyssa.
Thanks, Erica. So with something that is somewhat dense, I think it's really important to focus on the why. We all understand that diet-related chronic conditions, including diabetes and heart disease and cancer, are the leading cause of mortality and morbidity in our country. I think we've heard that multiple times today. But they're contributing to the deaths of nearly 1.5 million people each year and are accounting for 85% of the $4.5 trillion that we spend annually on healthcare. Food is medicine, as we all, I think, agree here. Interventions have emerged as an important strategy to prevent and respond to that epidemic, as well as rising healthcare costs and other multifaceted priorities, as we heard from Lindsay and the wonderful Rockefeller team. Specifically, the medically tailored meal intervention is a comprehensive process of delivering meals to individuals who are living with severe, complex, or chronic conditions using therapeutic evidence-based specifications for conditions, so very tailored, that's where that tailoring piece comes in, based on an assessment of the individual's nutrition needs by a registered dietitian nutritionist. Over the years, peer-reviewed research, much of which has been done on FIMIC's model, has shown incredible improvements in health outcomes and healthcare cost savings through adding this service to medical care. I think that's why everyone is so excited about food as medicine, is the research outcomes and the human outcomes. But despite this growing body of evidence, the Centers for Medicare and Medicaid Services has not ever explicitly allowed the coverage of the intervention under Medicaid and Medicare as a fully covered benefit. That is very different than the patchwork system of access we now have, leveraging flexibilities at the state level. So states have been able to provide Medicaid coverage for MTMs and other food as medicine services through those waivers and other flexibilities, but those legal flexibilities only create temporary coverage. So the problem is, because of this patchwork funding system, there's really a lack of standards and clarity across all of the states, all those varied programs, and stakeholders have faced roadblocks in successfully transitioning that temporary access, pilots, grant-funded programs, into healthcare reimbursement within the mainstream structure. And that's also led to a lot of variation as service providers and others within jurisdictions are repeatedly investing time and funds to develop answers to common questions across different partnerships. So we've seen the same pattern as other similar interventions that have developed in community, like community health workers or doulas or the diabetes prevention program. And if stakeholders don't take the time to take those legal requirements into account early in the development of programming, services can start to mature in a way that doesn't actually fit into the legal requirements of coverage when we get to that point down the road, when we're formally bringing these benefits into mainstream coverage. And so we're at that moment, which is an amazing place to be in food as medicine, where food as medicine services are being scaled in significant ways. Think of the Massachusetts evaluation that came out last year, or North Carolina, through ILOS, through supplemental benefits, et cetera. We're seeing this scaling. And we're also at an important moment to consider those legal frameworks so that we scale in an approach that is really sustainable for this service over time. So our goal and the impetus for the project we're talking about today, which is the MTM Sustainability Blueprint, is to grapple with those fundamental legal and regulatory questions for food as medicine services. And we're starting with medically tailored meals in Medicaid. And in doing so, we aim to create a foundation for program design and implementation that can chart that course to coverage over time. We consider legal requirements in healthcare coverage, and we map them onto MTM services, creating that roadmap for scaling. Importantly, I think, as you see at the bottom of this slide, which I have honestly not read fully, I'm sure you have at this point, but this is not prescriptive. It is in some ways a choose your own adventure. It walks the reader through the legal requirements and explains the choices that they present, and then outlines how a decision maker might navigate those choices given what we currently know about evidence and common practices in MTM implementation. The primary benefit of this blueprint is to make the journey smoother, to not accidentally or inadvertently create parallel systems of care where we're not taking those legal requirements into account as we're building in the flexibilities. So we hope that this is inherently useful. That's kind of a theme for FIMIC this year. Is it practical? Is it useful? And really think through those legal requirements as we begin to scale and to build within states. And with that, I'm going to go to the next slide to quickly get us to Erica, because of course we can't discuss the entire blueprint, but I want to give you a flavor of how to navigate each of the sections. So this has been a long project with a lot of thoughtful care in testing our assumptions. The first phase saw a drafting of the blueprint where FIMIC, Chilpy, and a group of other subject matters experts sort of drafted the initial responses to things like medical necessity and benefit category and very rigorous legal categories that we needed to respond to. It then went through a review with a second set of subject matter experts, the advisory group, and this was FIM practitioners, payers, providers, researchers, coding experts, community advocacy groups, and consumers, just to leverage their expertise and pressure test, again, those assumptions to provide feedback and response. And then it went through public comment, and then all of that was synthesized to produce what you see before you. While we're so grateful to all of the input and the public comment, the responsibility for the final blueprint is ours and Chilpy's. And I think it is really important to note that it is an evergreen document. As the evidence evolves, so will this blueprint. And with that, I'm going to pass it off to Erica to just walk us through 2 additional slides on how to understand these sections of the blueprint.
Thank you. We can go to the next slide. So federal laws and regulations create a broad framework for state Medicaid programs, their agencies, and then those states have the autonomy, the discretion within that framework to administer their own programs. And this includes kind of a wide latitude in benefit design. And so the blueprint's goal is to help those state Medicaid programs, the Medicaid managed care plans, other health stakeholders, and the MTM providers that are actually delivering services to talk to each other in the same language in order to fill in those necessary details to develop that covered MTM service, that benefit design. So as we've been saying, the blueprint outlines the necessary elements of benefit design for MTMs to transition from kind of the grant, pilot, and waiver-funded services that we're experiencing now to sustainable healthcare funding and coverage pathways. So the first step in this process was to assess the baseline legal requirements in 4 categories that Medicaid programs apply to all covered benefits. And so we looked at service coverage requirements, provider qualifications and requirements, service pricing and reimbursement, and monitoring and enforcement. And if we go to the last substantive slide, we'll see that within each of these 4 categories, the blueprint lays out the baseline legal requirements that all covered Medicaid benefits have to meet. It then applies these legal requirements to the MTM intervention, taking into account the current evidence and practice that we have for MTMs. It then identifies and recommends possible pathways for benefit design, service delivery eligibility, and other elements of program development that are compatible with those legal and regulatory constraints for healthcare coverage. Each section also contains application tips on how stakeholders can think about the blueprint in practice. So as Alyssa said, we don't have time today to walk through all the practical information in the 4 main sections of the blueprint. However, it's available now. I put it in the chat. And we hope that you'll use it to explore all of the options for sustainable MTM benefit design that your healthcare systems, your plans, and states can actually start to implement benefit design now so that you can create a coverable MTM benefit. Final slide.
Just to finish the presentation, Erica and I love to talk about this. So if you want to do a deep dive, just reach out to us on using this contact information, and we will be in the breakout room But why does this matter? I think it's really important to kind of bring it up to the top because it can get very technical very quickly. It matters because as a person who's a very passionate advocate for food as medicine, I think in very plain language, there's so much that we can already say about how MTM fits into healthcare benefits, and it's really amazing to see it laid out in the structure that healthcare understands. So food learning to speak healthcare's language and vice versa can only serve our clients better. Thank you, Julian.
Thanks, Alyssa. Thanks, Erica. And what you just said tees us very well up to hear now from Trina from Missouri.
Thank you, Julian. Hi, everyone. I am just giving an update today on some legislation that was filed in Missouri in the State House this session. That would essentially create the Food as Medicine Act for Missouri. We had 3 bills filed this session, 2 in the Senate, 1 in the House. SB 1075 and House Bill 2355 were essentially the same bill, and they all call on our state Medicaid agency to prepare and submit an 1115 waiver for food and nutrition services. And so those of us who are advocates and have been working in this field for years were a little bit shocked or surprised to see this legislation filed simply because the advocates had not been working on it. And so this actually is sort of related to Oklahoma's 2025 legislation. It just so happens that the Senate sponsor, Brad Hudson, his chief of staff, was working in the Oklahoma legislature during their 2025 session when their bill was filed and brought the idea to Senator Hudson and sort of was the impetus behind all of this happening this session. So we are thrilled that it looks like House Bill 2355 is moving forward at a good clip. We have 7 days left in our legislative session. So we're all kind of crossing our fingers and toes to see what will happen. But the language for that bill is both still moving forward on its own as well as being put into the state's healthcare omnibus bills. I don't know how many other states are like Missouri. We love omnibus bills at the end of session, right? So they have to be by topic. So in its original form, it's been included in this 131-page omnibus bill. They're both moving at a pretty good clip. So we're hoping to see what will happen by next Friday when they adjourn. One thing I did want to note that I talked to Julian a little bit about is there is a large fiscal note attached to House Bill 2355. And it's something I actually just reached out to Erica about as we were looking at it and got a little guidance from her this morning because it's sort of making the assumption that there are no sort of short-term financial benefits to doing this. So it's showing a cost of over $3 million a year in year 2 and 3 for implementing food as medicine with a very select small group of Medicaid beneficiaries, which will be a stumbling block or something that we're going to have to overcome as we're looking towards an appropriation to support implementation of this legislation. Next slide. So this is the part that I, as a local food system advocate, got really excited about, as well as a lot of the folks that I work with. And that is that this is a section from the bill. Whenever feasible, MoHealthNet will prioritize the inclusion of community-based organizations and local growers to support the purchase of locally grown food and nutrition prescriptions. So again, this was really exciting, especially to all of our food system advocates to see that this was written into the bill. And this is actually sort of what catalyzed what is becoming a larger movement to formalize food as medicine work in Missouri. Next slide. And Lindsay, I think this went perfectly with your report. I was really excited to see it and already have downloaded the snapshot for Missouri to share it. But one of the things I wanted to point out to you guys is with the widespread support. This is an incomplete list of everyone who testified in support of this legislation as it has made its journey through the state capitol, through the House and the Senate. And one thing I just wanted to point out to you guys is how many of these are food systems, farmers, food producers, parts of that value chain infrastructure, right? We have food hubs on here, the farmers union. So I think in the past, we have seen really strong support from the healthcare field. And this time, I think because of some work that's going on in the state concurrently, we also saw a lot of folks come out from every aspect or every sector of the food system. Next slide. And so what I was referring to is that back in January, I believe, of 2025, a group of food system advocates, mostly comprised of growers and distributors, representing small and mid-sized family farms, started a working group to begin working together to better understand what the possibilities were within the food as medicine movement in terms of engaging with local farm and food procurement and how they could potentially sort of insert themselves into that work as it was happening here in Missouri and capture part of it. And so we have a really diverse coalition that comes together on a monthly basis to discuss the different pilot projects that are going on across the state, to learn what is happening in other states, and has stood behind and testified in favor of this food as medicine legislation. I will say that it's already been mentioned today, but the Chilpy report, Maximizing the Impact of Nutrition Interventions with Local Food Procurement, is something we've actually studied as a working group. And one of the things we're working on right now is how we can work together over the next year and going into the next legislative session to strengthen Missouri's local procurement regulations. We have a fairly soft sort of tiebreaker regulation right now that we think we could potentially strengthen with more of a focus on supporting local food procurement. So that's one of the things that we are moving forward with, along with sort of facilitating the creation of a statewide food as medicine coalition that is more formalized than this ad hoc work group that started coming together. Because of the legislation and everything else that's been happening, it also has facilitated conversations with Mo Health Net Division and all three of our Medicaid managed care organizations. Right now, they all offer some sort of value-added food as medicine, value-based programs, and they're excited to come to the table. And actually, starting in this month, we'll be joining this working group. So we have the medical director and his staff from Mo Health Net coming to the table, as well as representatives from each of our managed care organizations who really want to help shape, should this 1115 waiver language pass, how we work together to formulate that with a focus on how we center local food procurement and our community-based organizations in the work that's going to happen in Missouri. I think this is also, I'll just say in closing, our thanks to Erica and her team at Chilpy. They're providing us with some short-term technical assistance as we look at formalizing into a statewide food as medicine coalition. Based on their recommendations, right now we're connecting with some of our neighboring states that have done this work more recently. And we're also trying to coordinate this with some of the other larger projects that are happening right now in the state. So I also happen to be working with a project that we have to create our first food system charter for the state as part of a larger healthy food financing initiative that we're working on. That is called the Missouri Rural Food Access Partnership, and we're bringing together almost 100 different collaborators from across the food system to look at how we center our local food system and what our priorities are moving forward. And food as medicine has been a theme for the first 2 years of these discussions in terms of an untapped opportunity for our local and regional food systems to become part of. And so as this healthy food financing initiative takes off in the next year, it will offer infrastructure funding. So funding for our food supply chain. And so we're going to try and make sure that we're sort of braiding these things together so that as we move forward with looking at the potential impact of food as medicine with our regional regional food systems, that we're looking at also how we can use some of these other projects to provide the necessary funding to grow that infrastructure. And with that, I will pass it back to you. Thank you.
Thank you. Over to Miranda and Gina.
Yeah, hi, good afternoon, everybody. I'm Gina Wood. I work with WVU Extension as co-director of the Family Nutrition Program, but I also co-chair the West Virginia Food is Medicine Coalition alongside Miranda. And just want to say thanks to Julian and his team for the invitation to share a little bit more about West Virginia's story. So our coalition, like I think so many others around the country, really wants to build the case for food as medicine and increase access to high quality food as medicine programs and services. And we are accomplishing that through highlighting participant experiences and building education outreach to our partners and identifying and filling some gaps in service. And above all, our goal is really to build and sustain infrastructure that can improve access to programs overall. And that sounds, I think, all kind of organized and intentional, but I assure you this has happened relatively quickly. So I want to rewind a little bit and share just a little bit of our backstory. So about 3 years ago, we were probably 10 or 12 people that were getting together virtually a couple of times a year to meet and talk about what we were doing as kind of boots on the ground food as medicine program implementers. And we came to realize, in our discussions that we didn't really have an agreed upon kind of solid definition of food as medicine. We were all defining it very differently. We were all evaluating our programs very differently, if at all. And so there was really kind of little communication or coordination, which created a lot of duplication across programs and competition for relatively small pools of grant dollars and philanthropic funds that were available across the state. So if you want to just transition to the next slide. So we conducted an environmental scan in the fall of 2024 that showed kind of exactly what we expected, which was like a patchwork of programs and funders with considerable gaps and overlaps in service. So we really recognized the need at that point to kind of build a foundation for a more comprehensive statewide approach to food as medicine that would really meet the needs of our rural communities, which are relatively unique. And we recognized, though, that we had a real lack of experience in coalition building, and we needed to engage some experts in that space. So we worked directly with Facing Hunger Food Bank, which is one of our 2 Feeding America food banks in the state, to secure a small grant from AARP to engage some consultants. And that was really our first kind of formal step to laying the groundwork for the coalition's development. So we were involved in writing some more grants over the course of the next year or so, and have secured, I think, enough funds to maintain relationships with those consultants over the next couple of years. And I'll acknowledge them here in a little bit. But if we want to go to the next slide, please. Our first coalition meeting was actually less than a year ago. So we are really, really young as a coalition, but it has kind of grown exponentially in a way that we never anticipated. So we have now over 150 member organizations, over 360 people on our listserv. We had our first in-person meeting last September, and we had over 100 organizations represented there. And we have about 80 people or so attending our quarterly calls for the coalition. So if we want to move to the next slide. So we have recently begun to formalize our structure and our membership. We have just recently, in the last month, put into place a 17-member steering committee that provides sort of broad geographic and cross-sector representation across the state. We have formalized our membership process, but I want to make it really clear that the work that we have done has been really in close collaboration, not only with our consultants, but all of our partners, all of these folks who have stepped up to volunteer their time as members of our steering committee. And we want to make sure that they're really fully recognized for their contributions. So next slide, please. So on the national level, we have engaged our consultant, Kristen Sukes. A lot of you know her. She has a lot of expertise in coalition building around food as medicine, and certainly is an expert in the policy space, especially when it comes to Medicaid. And we are also engaged with the Camden Coalition, who are providing expertise in building community care hubs for people with complex health and social needs. So the next slide before I turn it over to Miranda. And on the state level, we want to fully recognize the work that we have done with the Food and Farm Coalition. They have a significant history of building and providing leadership to local food sectors across the state. They've been our policy and advocacy partners in the SNAP Ed space prior to its elimination last year. And of course, we work really closely with our two Feeding America food banks, who have really been very tireless advocates for food as medicine over the past several years, and were instrumental in advocating for the passage of the food as medicine bill that Miranda is going to talk about next. So I'll turn it over to her.
Thank you, Gina. I'm Miranda, the Director of Health and Community Education at Family Care Health Centers. Very happy to be here. So I'm going to provide just some context about the policy and bills that passed this legislative session. So first, beginning in January 1st, 2026, our Department of Human Services implemented a SNAP Healthy Choices waiver, which prohibited the purchase of soda. So that they are in the process of implementing that. It is happening, and that's a good thing. Next, we actually were able to successfully advocate for HB 4982, which is also known as the Make West Virginia Healthy Act, and it was passed February 28th of this year. So we had actually, also very similar to Missouri, had written a food as medicine bill into the Senate and the House. Unfortunately, our Senate bill, it had strictly just food as medicine language in it, and a high fiscal note was attached as well. And so because of that, it did not go anywhere. So what did ended up happening is the food as medicine language that we had put in the food as medicine bill was put exactly into this HB 4982. So it was really nice because it was our language, but it was incorporated into this whole Make West Virginia Healthy. So in addition to food as medicine, it also reinstated the Office of Healthy Lifestyles, which all of that is aimed at combating obesity, diet-related chronic diseases through developing different programs, reinstating a Healthy Lifestyles Coalition. But within that, like I said, so for our food as medicine language, it did explicitly authorize food as medicine services under Medicaid, which included medically tailored meals, nutrition counseling, and nutrition prescriptions for members with nutrition-related chronic diseases. And we did very much resemble our language off of the Oklahoma bill for the food as medicine language. The other thing, it does authorize the Bureau for Medical Services to design programs to improve health outcomes for Medicaid members through nutrition supports, and required MCOs to partner with community groups. So very excited about that bill. I'm going to talk a little bit more about it in a minute, but I also wanted to say that we are actively working with the Bureau for Medical Services to develop their in lieu of services framework. So they had expressed that they were interested in a lieu of services option, or MCOs also were supportive of it. So that's why we really chose to go with that route first instead of the 1115 waiver. We were also concerned about the federal waivers being paused, and just thought that would be a much easier route to go through first. So we are in the process of discussing the language. The Bureau for Medical Services has included in their contract explicit ILOS planning language. So we're really excited about that to kind of pave the way for an initial ILOS pre-approval list. That is a tongue twister. And then also our food as medicine was included in our RHTP strategy. So under a personal health accelerator pillar, which we were really excited about. If you want to go ahead to the next slide. Like Missouri, we did also include language in this bill to prioritize the use of food grown or produced by local farmers and food producers in West Virginia. So really excited about that, because again, we know that food as medicine does create that demand for regional producers and enforces rural economic development. So that was one thing that we want to prioritize and make it important to stimulate our economy. If you want to go to the next slide. There were a couple of other elements that were included, like I said, in this bill. So they are creating a Healthy Lifestyles Fund, which is a special revenue account for funding to go towards these initiatives. They also advocated for the Department of Education and Agriculture to develop different initiatives around physical fitness, farm to school, school meal compliance, a food dye study, and a Feed to Achieve Act, which establishes a public-private partnership and a nonprofit foundation. So we've really realized with this that in West Virginia, they say they're fully supportive of food as medicine, but not everybody understands what food as medicine is. In the same article about the governor supporting it, he was talking about the Mountaineer Mile and physical activity. So we've really realized we have to really provide more education about what that is. I mean, it's important also to emphasize physical activity, but that's not food as medicine. So really that's an advocacy part that we plan to do over the next year, is really defining so that they understand what food as medicine is and making that clear to our legislators. They did also mention in the Make West Virginia Healthy Act about coordinating with Medicaid to develop an 1115 waiver. This was not something that we suggested that they do. They just put it in. So, we're not sure what's going to happen with that. We're, very happy if we get an ILS and an 1115 waiver, that will be wonderful. But it's not something, again, we're just, because of the political climate of 1115 waivers, we were a little nervous about pursuing that option. If you want to go to the next slide. So I just wanted to share a little bit about the RHTP opportunity. So these are the specific related goals and activities around food as medicine. So they talked about scaling food as medicine to prevent obesity and diabetes, to expand locally grown produce prescriptions across different health systems, to develop a shared referral and tracking system by funding data integration between EHRs and community resource databases, and then to partner with CBOs to build off existing program infrastructure. So it's definitely in there. We are really excited about that. Our governor has expressed support. The Department of Human Services and Department of Health have both expressed support. So just really excited about the support that we've had legislatively. If you want to go to the next slide. I'm just going to wrap up. So we worked with Kristen Sukes to kind of come up with a policy strategy. And honestly, we had the government asking us to come up with a strategy for rural health. So that's what you see here. I'm not going to go into all the details about it, but it basically is a roadmap that outlines a phased policy and infrastructure focused approach over 3 years. So from 2026 to 2029. And this is to establish, scale, and sustain food as medicine services within West Virginia's broader health system to create that infrastructure. So it's really important that we build the foundation, demonstrate the value, transition to financing, and then scale and integrate. So we're really trying to make this a part of our infrastructure instead of just relying on grant funding solely. We want it to be a Medicaid finance component of the healthcare system. And so that's our goal in all of this. But just really excited about the momentum around it. It's all happened very fast, and kind of like Missouri too. We didn't expect the bill to get passed, and it just came together. It was beautiful, and we're thankful and just kind of running off this momentum. So thank you. I'm going to turn it back over to Jillian.
Thank you so very much. So now we'll transition to our breakout rooms that will function as a Q&A space. Thanks so much to the over 100 people who stayed past the hour mark. I know it's really hard to dedicate an hour and a half to these things, but the fun is only just beginning. So now when you press the breakout rooms button, you should be able to see a menu of which room to go to. But if you have any trouble with that, you can also ask Katrina on my team, or just any of us from the MFSN team to direct you to the right place. And again, just to remind everyone, room 1 will be Lindsay from Rockefeller Foundation. Room 2 will be the Missouri and West Virginia Food as Medicine Advocacy. Room 3 will be Rich with the data dashboard on food security screening and other domains. And room 4 will be the MTM Sustainability Blueprint with Alyssa and Erica. So thank you again to everyone. We'll come back together at the very end, but just want to say before everyone runs off into breakout rooms, thank you again for being here today, and we thank everyone for the work and expertise they're bringing here. Thank you to all of our speakers. Thank you to all of you for staying to the very bitter end of the 90 minutes. My email address and also the MFSN email address is up on the slide. So please feel free to reach out to any of us, and also to we can get you connected with the speakers and our collaborators and all that. This is all in the interest of friends of friends being friends.